Hi all, once again a warm welcome to my YouTube channel Future Midwife. For the past few classes we were discussing about the normal antenatal conditions. So today onwards I just have a plan to step on to the another topic, that is labor. As you know, labor is a physiological changes by which the fetus and the uterine product expel through the birth canal into the external environment. Before moving to labor in detail, we just want to know the terminologies related to labor. So we will see one by one. The first terminology is parturition. It is the birth process. The second one is parturient. It is a woman in labor. Next is labor. It is a coordinated sequence of involuntary uterine contraction that result in effacement and dilatation of the cervix and voluntary bearing down effort that result in delivery, the actual expulsion of the product of conception, the fetus and the placenta. The next terminology is dystocia. It is an abnormal labor or difficult labor. Next one is eutosia. Eutosia is a normal labor. Last one is delivery. It means actual birth of the fetus. When we discuss about the essential factors of labor, when we think about the essential factors of labor, we just remind it is 5 P's. The 5 P's include passenger, passage, placenta, power and the psychological response. First we'll see about the passenger. The passage of the fetus through the birth canal is influenced by the size of the fetal head and shoulder, the dimension of the pelvic girdle and the fetal presentation and positions. The bones of the cranial vault are not firmly united. The bones of the cranial vault are not firmly united and slight overlapping of the bones or molding of the shape of the head occurs during labor. This capacity of the bones to slide over one another permit adaptation of the various diameter of the pelvis. Molding can be extensive, but with most neonates the head assumes its normal shape within about 3 days after birth. The fetal head can move on the neck about 45 degrees in flexion or extension and approximately 180 degrees during rotation. This movement permits smaller diameter of the fetal head to present during descent through the birth canal. So we'll see about the measurement of the fetal skull. It is very important to know the diameters of fetal skull. In anterior-posterior diameter, we have 3 diameters, that is occipito-mental, that is 13.5 cm, occipito-frontal, that is 11.5, suboccipito-bregmatic, that is 9.5 cm. When we discuss about the transverse diameter, there are 2 diameters, biparietal diameters and bitemporal diameters. The biparietal diameter is 9.25 cm, whereas the bitemporal diameter is 8 cm. Shoulders and pelvic girdle. Because of their movement, the position of the shoulder can be altered during labor, so that one shoulder may occupy a lower level than the other. This permits a small shoulder diameter to negotiate the passage. The circumference of the hips or pelvic girdle is usually small enough not to create problems during labor process. Next is the fetal lie. It is a relationship of the long axis of the fetus with the long axis of the mother. There are mainly 2 lies, transverse lie and longitudinal lie. In case of longitudinal lie, the long axis of the fetus is parallel with the long axis of the mother. So whereas in transverse lie, the long axis of the fetus is at the right angle to the mother. Then we'll see about presentation. Presentation refers to that portion of the fetus that enters the pelvis first and cover the internal os of the cervix, such as cephalic bridge or shoulder. The last content of passenger is attitude. Attitude is the relationship of the fetal body parts to each other. The universal attitude of the fetus is both arms crossed towards the chest, back is markedly flexed, head is flexed towards the chest, thighs are flexed towards the abdomen, and the knees are flexed in the knee joint. So this we called it as a universal position of the fetus inside the uterus. In cephalic presentation, if the head is fully flexed on the chest, the occiput present first and the posterior fontanelle is palpable on vaginal examination. This is termed as an occipital or vertex presentation. If the head is partially flexed or not flexed or moderately flexed, the anterior fontanelle is present and it is palpable on vaginal examination. This is termed as sinciput presentation or military attitude. If the head is markedly extended, the brow is the presenting part. This is termed as brow presentation. If the head is hyperextended, the chin is presenting part. This is termed a face or chin presentation. Here we discuss about the causes of onset of labor. The causes of onset of labor we can divide mainly into two: hormonal factors and mechanical factors. In case of hormonal factor, there are many hormonal factors which helps in the onset of labor. That is estrogen theory, progesterone withdrawal theory, prostaglandin theory, oxytocin theory, and fetal cortisol theory. When it comes to the mechanical factors, there are two mechanical factors also helping the onset of labor: uterine distension theory and the extension of lower uterine segment theory. The first hormonal factor is estrogen theory. During pregnancy, most of the estrogen are present in the binding form. During the last trimester, more free estrogen appears, increasing the excitability of the myometrium and prostaglandin synthesis. The second one is progesterone withdrawal theory. Before labor, there is a drop in progesterone synthesis leading to predominance of the excitatory action of estrogen. The next hormonal factor is prostaglandin theory. Prostaglandin E2 and F2A are powerful stimulators of uterine muscle activity. In case of oxytocin theory, although oxytocin is a powerful stimulator of uterine contraction, its natural role in onset of labor is doubtful. The secretion of oxytocinase enzyme from the placenta is decreased near term due to placental ischemia, leading to predominance of oxytocin's action. The last one is fetal cortisol theory. Increased cortisol production from the fetal adrenal gland before labor may influence its onset by increasing estrogen production from the placenta. The second factor is mechanical factors. The mechanical factors include uterine distension theory. Like any hollow organ in the body, when the uterus is distended to a certain limit, it starts to contract to evacuate its contents. This explains the preterm labor in case of multiple pregnancies and polyhydramnios. The second mechanical factor is stretch of the lower uterine segment. Usually the stretch of lower uterine segment occurs by the presenting part near the tail. Okay, now we can discuss about the clinical pictures of labor. The clinical pictures of labor mainly can be divided into two ways. The first one is prodromal stage, that is pre-labor stage. The second one is onset of labor stage. The prodromal stage include shelving, lightening, pelvic pressure symptoms, excessive vaginal discharge, and presence of false labor pain. When it comes to the onset of labor stage, it include presence of true labor pain, show, dilatation of the cervix, and formation of bag for water. We will discuss about the prodromal stage. The first one is shelving. It is falling forward of the uterine fundus, making the upper abdomen looks like a shelf during standing position. The second one is lightening. It is the relief of upper abdominal pressure symptom as a dyspnea, dyspepsia, and palpitation due to descent in the fundal level after engagement of the head and shelving of the uterus. Next one is pelvic pressure symptoms. With engagement of the presenting part, the following symptoms may occur. The first one is frequency of maturation. Second one is rectal tenesmus. The third one is difficulty in walking. These are the pelvic pressure symptoms. The fourth one is increased vaginal discharge. That everybody knows that increased vaginal discharge before onset of labor. And the last one is false labor pain. Most of the women experience false labor pain before the onset of labor, and also sometimes we may mistakenly it as true labor pain. When it comes to the second stage, that is onset of labor, which include true labor pain, they show dilatation of the cervix and formation of bag of forewater. So here the show is the bloody discharge which occurs before the onset of labor. That means just before the onset of labor. The true labor pain we can identify. Along with the pain there will be a cervical dilatation also. So usually the dilatation of the cervix occurring according to the uterine contraction. Once we get the rhythmic proper uterine contraction, the dilatation of the cervix also will be proper. Last one is formation of the bag of water. So usually the formation of bag of water will be present on the presenting part. Next we will see about the physiological effect of labor. In physiological effect of labor can be divided into first stage, second stage and third stage. So in the first stage, on the mother there will be minimal effect or minimal sign and symptoms will be happen during the first stage of labor. When it comes to the second stage, there is some variation in the temperature. Slight rise to 37.5 degrees Celsius. Pulse increase up to 100 per minute. Blood pressure, systolic blood pressure may rise slightly due to pain, anxiety and stress. Edema and congestion of the conjunctiva. Minor injuries to the birth canal and perineum may occur, particularly in primigravidas. The third stage, the blood loss from the placental site is 100 to 200 ml and from laceration or episiotomy is 100 ml. So the total average blood loss in normal labor is 250 ml. On the fetus also there is some changes happen, that is molding. The physiological gradual overlapping of the vault bone as the skull is compressed during the passage in the birth canal. One parietal bone overlaps the other and both overlap the occipital and frontal bone, so the fontanelle are no more detectable. It is of a good value in reducing the skull diameter, but severe and or overlapping molding is dangerous as it may cause intracranial hemorrhage. Here we can wind up today's section. The nursing management during first stage of labor will be displayed on the screen. Please have a look. So next class will be the continuation of today's section. So don't miss it. Till that, take care. Bye bye.